Thank you so much. I have the honor to give the last talk, and yet I'm still very honored to be here. We heard so much today, and the IPC think tank is there to evoke discussion, and I hope with my talk that I will add some more things to the discussion that you will also maybe choose to be an unmet need, and that is how we can integrate all those data in our dermatological practice. We heard a lot what the dermatologist could actually be doing, looking at psoriasis in a different way, looking at comorbidities, choosing the right drugs to also treat the patient as a whole. Unfortunately, and that's what I always come across when I give talks about integrated care for psoriasis, the current healthcare climate, especially the budget, makes it difficult to coordinate care, manage and take ownership of other medical problems than the skin, and verify the follow-up. And I want you to think with me how we can improve that. And the only way, to me, is that we collect more data on showing how beneficial it would be if we would have the budget to look at the patient as a whole, as was mentioned just a minute ago. Good. There are definitely hesitating papers on integrated approaches. This is from a few years ago. In other types of journals, people I don't know talk about new models of integrated care. Also in nursing literature, you see a lot on integrative approaches in which nurses definitely can play a major role in my eyes. I go to my clinic and I will show you along my presentation some data of a cohort of patients that we are following up upon in a very close manner and a very broad manner. And these are only 100 patients that we followed up for 1 year, and this was their baseline characteristics when they came to our clinic in Ghent in Belgium. They are not so much the most difficult patients, because in Belgium we don't have a step-up system, first GP, then dermatologist in the street, and only then academic or tertiary center. So everyone can come to our clinic, which is a tertiary center. So I'm still amazed that we have moderate to severe patients, half of them, and that they are undertreated. We are 2025, still people in the streets are running around being undertreated. Yet the quality of life is highly burdened, as you can see here in our measurement. And also they suffer a lot from symptoms. 88% even says we have severe symptoms like the itching, the pain, etc. So 2025, I'm really surprised about that. And related to the IPC think tank, I was also going to show, or I show these results to really show that psoriasis is definitely a multi-morbid condition, like many other ones, like IBD, like certain arthritis, etc. So at least 3 comorbidities in 1/5 of the patients you see here. And no one has, or only 6% has no comorbidities. Which are the comorbidities? And some words have fallen off here, but I can tell you that obesity and overweight are highly prevalent in our Belgian Caucasian patients, hypertension. There was also, some words have fallen off, but what struck me is that psoriatic arthritis is not so prevalent. Arthralgias, I think, are less of a problem nowadays than overweight, obesity, hypertension, and now I remember dyslipidemia was really at the top here. So highly prevalent. That is because we measure that and we document that and we put some time in measuring and getting all those data in our patients so that we know we have in front of us the profile. What is the profile of our patient? And you've seen these data. These are the data from your answers and surveys to the questionnaire sent out by IPC. You do screen for signs and symptoms of metabolic disease, which is a very rational thing to do. You don't screen all of them. You have a subset of patients that you screen, and you seem to like the BSA more than 10% patients, also the ones with high impact sites, additional risk factors for metabolic disease like smoking, overweight, etc. So you seem to select a subpopulation in which you do a more elaborate screening. I liked the other responses as well. It seems like you expect the primary care physician to do that, and in case he or she did not look at metabolic syndrome parameters, you start doing it. But you still seem to see that as something that the primary physicians should mainly do. You also select individuals with the typical risk factors for metabolic disease, and you also link it to the fact that you will start systemic therapy. So to me, it seems like the mild psoriasis patients that you might put on a topical, you don't screen for metabolic disease. What do you do is shown this morning. I should not repeat that. And then I go to our clinic. I think our group is well known to have come up with a kind of pilot or a model for integrated approach of psoriasis, not only psoriasis, but also hidradenitis, vitiligo, atopic dermatitis. We believe by profiling the patient in a very extensive manner, we can act better on what the management for that typical patient should be. And of course, it takes more time and more resources. And here I already touch upon, is there a budget to do that? We call our consultations plus consultations because we are so convinced that they are an added value as compared to regular dermatology approaches. We published on our, what we call an integrated practice unit. So we integrate all the needs for a patient actually are addressed. We take the lead in referring to the right departments, also outside of the hospital, so we take the lead in managing the psoriatic patients for not only the skin, but also for their other comorbidity problems. And this is how the process looks. You might say, well, this costs a lot of time. Yes, but our hospital has a protected GDPR-proof link, an electronic link to the homes of the patients that have made an appointment. So they have to open that link and fill out questionnaires. Also, they get an assignment to go to the GP to do all the blood and urine work. And we also give them an educational movie so that they know about our approach and why it is so important to look at the whole person. And then the patients come to our clinic, which is here, and the nurse takes the majority of the time, profiles the patient really extensively, and the dermatologist, which is the most expensive co-worker in this whole process, actually limits his or her time in dealing with the patient. We do the clinical exam, maybe we add some testing, and of course we choose the right treatment. But the majority of time is at the home and with the nurse. And we look at 13 comorbidities, not in the least obesity, cardiovascular problems, but of course also other ones. We look at lifestyle, and we use cutoffs to say, oh, you need a referral, or you don't need a referral. We have taken all the cutoffs from literature to decide upon that. And this is a typical man, 33 years old, with psoriasis since the age of 16. He is now on guselkumab, and he is also in our BIO study, which is a dose tapering study in regular biologics. And so this is also a way to bring down the costs. So he is in the dose reduction arm, and I can tell you that he still is after the study has finished. So he's on half a dose of guselkumab, which is less costly. He has very good results, of course, but normally you would send that patient home maybe and say, I need to see you once a year, no blood work needed, you are fine. But actually when you do the blood work and look in a holistic manner, you see his blood pressure is constantly raised, he has a lipid disorder, luckily he's not a smoker, and he has a slight overweight. And then we used the heart score risk calculator. And we took it up ourselves because we warned the GP at several occasions, you need to look into this, but the GP did not do that. They don't all do that. And so we calculated the risk ourselves, and I can tell you that this patient is actually, even though he's only 33 years old, he has a bit of an elevated risk for cardiovascular events, and that's why I started a statin myself. And using this calculator is also very educational. It's striking for the patient to see that, and it's also a means to talk with the patient and motivate the patient to change their way of living. So this is how we work, and what I saw in the survey is one interesting saying or one interesting piece of text in the survey that came from you. There is a gap between what is needed and all the things we heard today and logistics of achieving this in a busy clinical setting. The ideal would be that such screening is considered an essential part of review. But the majority of dermatologists, also all over the world, when I give this talk, they say, well, you work in an academic center, money is not so important, you have nurses, and okay, you have your salary because you are employed by the government. Okay, then we should maybe turn it around and not say we don't have time for that, but actually seek how we can make time that is paid to also enhance and level up the status of the health of a psoriatic patient. So we should not put the cart, put the cart before the horse. We should try to find how to reorganize in a possible manner and also make sure that there are resources to really come up with a holistic screening of our patients. And then how can we show that integrated care is beneficial on the long run? Because this is something we believe in, we highly believe in, that, okay, we take more resources to start with and to put or to bring the patients on a better health track. And on the long run, this will pay back because we have healthier citizens that can go to work and that need less healthcare consumption, presumably. But actually, we need data to convince the policymakers that they should pay us for integrated care because we know it comes at a higher cost. And this is why we have started the work on what is a patient-relevant outcome set? What are the goals we need to achieve in a patient with psoriasis? And some of you have collaborated on this wheel, which is now finalized in a consensus, not yet published. So you have patient-reported outcomes that you want to improve and reach a target. We also have clinician-reported outcomes. But actually what is interesting is also in the wheel is the fact that comorbidities should be under control. Are they still there or are they under control is also something you together with us want to achieve. So this is when you reach good outcomes in these 16 domains, you can say you bring the highest value to your psoriatic patients. And comorbidity control is one of them. And there I jump to my favorite topic, value-based healthcare, which is more and more introduced in healthcare environments, also in big countries like Singapore, Saudi Arabia. The governments are taking this up. The governments invest in healthcare up to 18% of their GDP. But then, of course, they want to see what's the return on our investment. And if we don't have an outcome set, or if we don't have a suggestion on what is value, what is the best outcomes that we want to reach in our patients, we can never defend ourselves if they say, well, I will bring down the budget for healthcare in psoriasis because yeah, we think we have to. It seems like a nice saving. If we cannot defend ourselves, yeah, then we are nowhere. We try to educate dermatologists on the concept of value-based healthcare. So you play around all the time with, okay, you have inputs, you put in money, resources, personnel, treatment costs, but what comes out of it? What are the outputs? And this is what we play around all the time. Next slide, yes. Integrated practice unit is where you get this value, and this is how we are organized. We are in the middle, but we have direct lines to all kinds of specialists, and we coordinate this. This is how our EHR looks like. It's like a registry checklisting so that we don't forget anything and the nurse doesn't forget. And we also are now measuring how much it costs to put a patient through the whole process, and not just stopping in dermatology, but also bringing the patient to the referral departments and coordinate this. So we have highly documented patients in which we want to achieve the highest value, including comorbidities, and we are measuring how much this costs. So here you see all the inputs, and here are the euros that, so the inputs are the euros, sorry, and the outputs are in the numerator, PASI, DLQI, comorbidities under control. And this is a new approach to efficiency in healthcare, which is called data envelopment analysis, and you play around all the time with costs versus outcomes. And when your efficiency score is 1, you are highly efficient. You use every euro you have to get the best results and achieving the best results. If you have less than 1, let's say 0.5, you know you can maybe add on, you can look at your process and make it more efficient to really reach that 1. So that's a whole new thing. So we have been measuring costs according to time-driven activity-based costing, but you can also use cost drivers for the denominator. And what I can tell you is that if you only look at the skin, it is less costly. If we include looking at comorbidities, there is an add-on here in the mean of, let's say, 1.2 to 2 points the cost reimbursement to cost ratio. So it does cost more money, but if on the long run you can show that you save by looking in an integrated manner, of course, this is what we want to get. And then I come back after 1 year to my patient to end with PASI, psoriasis-specific outcomes with our approach are dramatically going down. Also, the symptoms go down. This is our psoriasis treatment. Of course, this is because we treat much more rapidly with systemic therapy, like oral and biological therapy. So we bring the patients to the best treatments. And let's look at comorbidities after 1 year. So we put more efforts to screen and to refer to the right department. So these were the initial comorbidities that we saw, and I will go through a few of them. So cardiovascular risk factors, like dyslipidemia. We advised patients to go to the GP. Only 1/5 really goes to the GP, so there is also a patient factor, but you see that we have, after 1 year, less uncontrolled dyslipidemia. Then I go to overweight and obesity, a very difficult one. Only 10% of the patients goes to the obesity clinic that we advised, and obesity and overweight are almost not changed after 1 year. This is not with GLP-1 agonists. Hypertension is easy for us. They go to the GP, they get a treatment, and so we have a lot less uncontrolled patients. Diabetes is also quite well taken care of in Belgium with diabetes educators. So that also goes down, and metabolic syndrome also goes down. So the level of uncontrolled patients also goes down. So it pays off. We have not yet put it in a large health technology assessment approach, but I believe these are the data we need to convince on the long run the governments, give us money for coordination and we will coordinate and you will benefit from it on the long run. Nevertheless, patients also need to be convinced, and a patient expert told me that trying to convince patients is a lot about emotions. They need to feel the urge. Of course, you need to give them knowledge, and only then will 15% of them start doing. But going at micro level to a patient and have him understand why you do all this, it also has to match with their personal expectations, which is another thing. And you can also work with patient experts to enhance this, because we really saw that we are not so successful, for instance, in trying to get them to an obesity clinic. Good, I'm ending here. I have been bringing, I hope, some points for discussion in the IPC think tank that should be. So I have some yes, no. My statement is we are in the lead as dermatologists to organize the full cycle of care for psoriasis patients. So we are the ones referring to whatever service they need in the hospital or outside the hospital. Second one, by documenting value with the patient-reported outcome set that we have been working on together with you, we can show that we save budget on the longer run because our gain is really documented. And last but not least, there is probably a profile of psoriasis patients that need more integrated attention, and I'm also saying there, maybe there is a subset in which we have some overkill in taking so much time for them. So maybe to stratify certain patients would also be more budget friendly. And I hugely thank my team here in the fields of Flanders and the river Leie next to Ghent. Thank you.
Thank you, Jo. Excellent presentation and the ideal world. I don't think my government will accept that. It's very hard. Any questions for Jo? But maybe we can do what we can do on a limited, you know, not this ideal. This is wonderful, but go ahead. Yeah.
So thank you very much. This was an excellent presentation. I really do like your ideas. So I think we have integrated the clinics with rheumatologists and gastroenterologists, but I don't think, we spoke about it around this table with you, Gelfand, before lunch. I don't think we have good connections with the family physicians as a discipline. Mm-hmm. And I do think that, and I said it in advance, that IPC should be finding some way to collaborate with general physicians, because actually we should not ask for budget to treat the diabetes and hypertension dyslipidemia for the patient. This is the GP role, right? So it's not our role to get budget from the government to take care of these patients, but we do need to integrate our treatment with the family physicians. That's my take.
Well, one specialist has to take the lead, and I have the impression that the dermatologist is the best position, because GPs, I mean, they see 1,000 diseases, and if they would have to know all the guidelines, I think they are a partner in the wheel, and I think we should have the coordinating fee from the government as dermatologists. And I copied this to HS, to vitiligo, to AD, because they are all multi-morbid conditions in dermatology, and we have a great future there to take the lead, I believe. Yeah. Yes.
Hi. Thank you for your lecture. Well, actually, I want to share some experience with the thing. In our center, my office is just opposite to bariatric clinic, where we have all they need, you know, dietitian, endocrinologist, and surgery. And the mean BMI of my patients are around 28, if many of them are more than 30. For my experience, and what I tell them, I go, okay, let's come with me across the corridor. And there are many specialists that care about you, and only 50% of patients agrees just, you know, to cross the corridor. And only 30 or 20% of them will continue. So the problem is to convince the patient that obesity, I think, is a disease, because the perception of the obesity for many patients, from my opinion, is like a habit, or I don't know, or maybe I don't have enough skills to convince the patient just to get treated. This is the one problem. And, you know, only smoking may be harder than obesity treatment. And the second one, that some patients they say, okay, give me the injection. You mentioned the injection for obesity, okay, prescribe it to me. Mm-hmm. And then I feel that I'm not skilled enough to treat obesity with new medications and, you know, side effects and to follow up and et cetera. So maybe we should indicate our patients that obesity is a disease, our psoriatic patients, I mean, and maybe we should be more educated about treatment of this disease.
I think the secret lies in repetition. I can only show the data from after 1 year, but I'm sure if I show you the same cohort in 5 years, we will have reached much more. And those things like obesity are so emotional sometimes that it takes time. There is an inertia to it, but you need to keep on hitting on the same nail all the time. And I also don't feel skilled, but I send them out each time. And once a year, we meet with the whole integrated practice unit professional group, and we couple back those data. And then we see where can we improve. So there is a continuous improvement cycle as well.
Just a quick, so I loved your feeling, knowing, doing slide, but the implication was patients. To me, the same thing is applicable to dermatologists. There's so many dermatologists that still don't use biologics.
Yeah, it's crazy.
So that feeling, knowing, doing is relevant to doctors too. You know, they know what
it's culture change. It's challenging yourself, and how can we challenge with the IPC? We can bring deep motivation. I think with the communications we bring. Yeah. Okay. Thank you.
Thank you so much, Jo.